Today we'll be discussing Chapter 40, Fluid, Electrolyte, and Acid-Base Balance. And after you review this chapter, you should be able to describe the location and function of body fluid, including factors that affect variations in the fluid compartments, describe functions, regulation, sources, and losses of the main electrolytes of the body, explain principles of osmosis, diffusion, active transport, and filtration, describe how thirst and the organs of homeostasis, the kidneys, the heart, the blood vessels, the lungs, the adrenal glands, pituitary gland, parathyroid glands function to maintain fluid homeostasis, describe the role of the buffer system and respiratory and renal mechanisms in achieving the acid-base balance, and identify etiologies and defining characteristics for common fluid, electrolyte, and acid-base imbalances. Also be able to perform a fluid, electrolyte, and acid-base balance assessment. Describe the role of dietary modifications, modifications of fluid intake and medication administration, IV therapy, blood replacement, parental nutrition in resolving fluid, electrolyte, and acid-base imbalances, and assess, plan, implement, evaluate nursing care as it relates to select nursing diagnoses involving fluid, electrolyte, and acid-base imbalances. In your role as a nurse, if you're working in a hospital setting, you'll be caring for post-surgical patients, and most of these med-surg patients are going to have IV fluids that infuse during their admission. And because we frequently use IV fluids on the floor, you have to be able to understand fluid balance and electrolyte function. All right. There's also some other scenarios where you might need to know this, like in renal failure or congestive heart failure. So what kind of conditions might cause fluid volume overload or hypovolemia? How would you determine if patients lost fluid? How would you describe hypovolemia or third spacing of fluid? And how do they correlate with one another? What kind of changes are you going to see in the body when one or the other happens? And what is the difference? What are the major differences between hypovolemia and third spacing of fluid? Also, what other kind of conditions can occur when our fluid does third space? So here you're in the hospital and you're taking care of a 78-year-old gentleman that came in, and he has an infection, and you need to give him IV therapy with antibiotics. And you just started the IV therapy a little while ago, and it's been running for about, an hour or two now. And all of a sudden, your patient calls you to the bedside, and they're having difficulty breathing. It just started a little while ago. You do an exam on them. They have a full bounding pulse, distended neck veins, and you can hear crackles and wheezes in the lungs. What's your diagnosis, nurse? What's going on with this patient? Okay, so you start to check, and what you see is that your patient has fluid volume overload from administering these fluids. And what has happened is they've actually ended up in fluid volume overload, or what we call overhydration. So very important that you know about the fluids, the different types of fluids, and how those fluids work. So fluid and electrolytes are extremely important to maintain life, and we have to have a proper balance at all times. They help with all cellular reaction and function throughout the body, and these chemical reactions occur in the body to maintain this acid balance and base balance. Okay, so the main body fluid is water, and water is one of the most important nutrients of life. Okay, without it, we really can't survive longer than a few days. So water helps with a lot of things throughout the body. Okay, it helps to transport nutrients and remove wastes. It's going to help transport hormones, enzymes, platelets, both the red and white blood cells. Okay, and this is important, right? And this is why we tell our patients all the time that they need to drink a lot of fluids. Okay, because let's say our patient has a problem going on with the blood. If they're drinking extra fluids, it's going to help that blood to keep flowing, especially if it's thick, sticky, viscous. Okay, water can help with that. How about constipation? Okay, water can help us to make elimination from the body by promoting that constipation. We absorb the water and it helps the stool to move along. When we don't have enough fluid, then the stool becomes hard and we become constipated. Uh, Water helps to break down different chemical functions in the body, so it serves as a solvent for both electrolytes and non-electrolytes, and then it facilitates that cellular metabolism or that breaking down. It also can help us maintain a proper body temperature, and it acts as a lubricant throughout the body for a number of things, tissue in general. But there are fluids, throughout the body that help with gliding and movement of things throughout the body to avoid friction. We talk about total body water. This is the total amount of water that is in our body weight. So our total body water is the amount of our weight that is in water. For most adults, that's going to be about 50 to 60%. So the fluid is located in two main compartments, the intracellular or in the cell and extracellular outside of the cell. The intracellular fluid makes up about 70% of the total body water or 40% of our body weight. The extracellular fluid makes up about 30% of the total body water or 20% of our total body weight. Extracellular fluid includes two major areas, intravascular and interstitial. The intravascular is that liquid component of our blood, and interstitial is fluid that is around the tissue cells, and it also includes the lymph fluid. There's also a minor compartment called transcellular fluids, and this includes things like cerebral spinal, pericardial, synovial, intraocular, and pleural fluids. It also includes our sweat and our digestive secretions. Now, in a healthy adult, the total body water is about 50 to 60% of the body weight. With infants, their body weight and fluid is going to be more about 90%, and they're more prone to fluid volume deficits. Okay. Also, variations can occur based on someone's gender, the amount of fat cells they have. Obese people and women tend to have less body water. So that means they're going to be at a greater risk for dehydration. Okay. Fat tissues don't like water at all. So it makes a lot more work for the body. And so that's a problem for these people. Okay. Also, as people tend to get older, we'll see an increase in fat cells and they lose muscle mass. Okay. So that also reduces the total body water. So after about 60, the body water starts to go down to about 45%. And that also puts the patient at a greater risk for fluid imbalance. So older, higher risk. So when you think about your most at-risk people for fluid imbalances, okay, some of the people you're going to consider are obese, infants, and older people, geriatrics. So this diagram is showing you the breakdown of the fluid inside the cell, outside the cell, showing you that the total body fluid is equal to about 50 to 60% of our body weight. Again, that's for a normal adult. Okay. For a geriatric population, it's going to be about 45%, and for babies, about 90%. All right. So this is why those populations are at greater risk for dehydration. So those risky populations, the elderly, the obese, the infant. Okay. So we have this, fluid in our system that we get from, a lot of different places. We get it from foods that we intake from certain foods, okay, like watermelon, cantaloupe, they're high in fluids, tomatoes, and also they can be a result of metabolism. Okay, so the greatest amount of fluid taken into the body obviously comes from what we consume. All right, and then fluid is the fluid intake itself is regulated by the hypothalamus. Okay, we have a thirst center in there, and that thirst center will stimulate the body through something called ADH. Okay, so like let's say you were walking across the Sahara Desert, and all of a sudden you got really thirsty. Your body from the hypothalamus would stimulate the antidiuretic hormone from our what I call our PP gland, our posterior pituitary gland, and when it stimulates that ADH, okay, it causes antidiuretic hormone, by the way, meaning it's not going to allow us, it's going to control our diuresis, okay, or our urine output or our fluid output. With ADH, it really controls the water output, okay, not sodium or other electrolytes, just water. So our body releases this ADH from the pituitary gland, from the posterior pituitary gland that's stimulated by the hypothalamus, okay? So it releases this ADH and it says, hey, wait a minute, I'm feeling really thirsty here. So you need to start conserving fluids. Okay, so what it does is tells the body to stop sweating, stop urinating, and it releases this ADH. And that antidiuretic hormone, that ADH, stops us from sweating, stops us from putting out excessive fluid, so the body can start to conserve this fluid. This is what we call a compensatory mechanism, okay, and it's trying to save us so we don't become dehydrated. When we become dehydrated, we lose, okay, or we have a deprivation of water from our body tissues, and that's going to cause a decrease in our blood volume. This means that we're not going to have as much blood to circulate throughout the body. So some organ is going to suffer behind that if we don't have enough fluid to circulate, because the body is going to start to conserve. All right, and it's going to conserve the fluid for the organs that it feels that it needs the most. And the body's always trying to stay in homeostasis and help itself out. So it has these little mechanisms that it's constantly doing. All right. So the amount of water ingested can really highly depend on your diet. Again, as I said, things like watermelon, cantaloupe, they're high in water content. But things like cereal, dried fruit, they're low. Okay, so water also can occur or be produced through oxidation in the body. Okay, like when we break down things like carbohydrates, fats, and protein. So in general, fluid intake averages about 2,600 mLs a day, and then about 1,300 of that come from water that we actually drink, and about 1,000 comes from ingested food. The remainder comes from oxidation in the body. Remember, when we lose fluids, we lose it through both sensible and insensible losses. Sensible losses are things that we can measure, like urine. Insensible are things that we cannot measure, like sweat or respiratory. So electrolytes is what we're going to talk about next. Electrolytes are essential for functioning throughout the body. Okay, they break down into something called ions. And we have both positive and negative ions. Our positive ions are called cations, and our negative ions are called anions. If you think about an ion, you could think about without charge or negative charge. That might help you remember it a little better. Okay, so for the body to be in homeostasis, then our cations have to be equal to our anions. So these ions themselves are molecules that carry electrical charges. Again, if it's a cation, it will have a positive charge, and those are going to be things like sodium, potassium, calcium, hydrogen, and magnesium. Other anions, which have a negative charge, okay, these are in the body fluids, and they're called chloride, bicarb, and phosphate. And they help with chemical interactions throughout the body, metabolism, okay? And then we have some molecules that remain intact at all times. They don't break down, okay, because they don't have a charge. They're called non-electrolytes. And these are things like urea, glucose, those kind of things. So if you look at table 40-1 in your book on 1559, it really breaks down what each electrolyte does, what its function is in the body, and how we lose it, and how we gain it, and also how we regulate some of those things throughout the body. So you might want to take a good look at that table. Now, before we move on, let me ask you a question. Which of the following patients are at highest risk for fluid and electrolyte imbalances? A woman that is 45 years old, an infant that is 4 months old, an adolescent that is 17 years old, or a man that is 50 years old? Which client is at greater risk for fluid volume deficit? A woman, 45, an infant, 4 months, an adolescent, 17, or a man, age 50. So hopefully you said the infant, age 4 months. Remember, their bodies are about 90% water. They're at highest risk, those and the elderly, and then also people with obesity. Extracellular fluid is more easily lost from the body than intracellular fluid, and infants are more prone to fluid volume deficits. Okay, so now we're going to talk a little bit about solvents, okay, and solutes. So we already said that the body has to be able to maintain fluid and volume and electrolytes. Okay, this is essential to us to be able to function. All right, so in our body we have something called solvents, and our main one is water. This helps hold things in the liquid, mainly these solutes. Okay, it helps hold them in that solution. So the solutes are substances that are dissolved in that solution. And water is the primary solvent in the body, and then the solutes are the electrolytes and the non-electrolytes. So we have things like the potassium, the sodium, and then the non-electrolytes like the urea and the glucose. The body maintains the balance by shifting the fluids and the solutes back and forth between the intracellular and the extracellular spaces. And it's different organs throughout the body, different compartments, osmosis, diffusion, active transport, and capillary filtration that all ensure that these processes happen throughout the body. All right, so major electrolytes in the body is what we're going to talk about now. All right, for one, sodium. All right, sodium levels are normally 135 to 145. They help to regulate the volume of fluid. When we lose sodium, a lot of times it's accompanied by a loss or gain of water. It can affect the osmolarity of the blood. Its role is in contraction and transmission of nerve impulses besides regulating that body fluid. And also it helps regulate the acid-base balance as sodium bicarb. Now, we usually intake sodium in the GI tract, okay? It goes into the body from that GI tract. We get it through foods, and we lose it through the kidneys and the skin through way of sweating. Okay, it's transported in and out of the cell by that sodium-potassium pump. It's regulated by the renin-angiotensin-aldosterone system and eliminated and reabsorbed by the kidneys. And then concentrations are affected by salt and water intake. Usually when we talk about fluid, when we talk about electrolytes, okay, and the way that they affect the body, Usually if something is too much, if we have too much of an electrolyte, it has a hypo response to the body. And if we don't have enough, it usually has a hyper response to the body. So we'll talk about that a little bit when we get to like magnesium and calcium, all right, and how that can affect. Potassium, this normal value for potassium should be 3.5 to 5.0. It controls the osmolarity inside the cell. Okay, remember that's the strength or the concentration. It also regulates enzyme activity. The role of potassium is also very important when we talk about electrical impulses, especially those in the heart. Okay, it can cause cardiac arrhythmias if the levels are off. The nerves, the skeletal muscle, the intestines, lung tissue. It also helps regulate the acid-base balance through exchange with hydrogen ions. We get potassium through a lot of different foods. Okay, we need a well-balanced diet. Foods that can bring us potassium include fruits, vegetables, peas, those dried peas and beans, whole grains, milk, meats. We lose potassium through our kidneys, through our stool, through sweat, and through vomiting. It's regulated by the kidneys, aldosterone, and through the shifting of fluid between the intracellular and extracellular compartments. You have to watch potassium. Levels that change can cause cardiac arrhythmias. Calcium is the most abundant electrolyte in the body. Our levels for that are normally somewhere between 8.6 and 10.2. It helps in the body with coagulating the blood and transmitting nerve impulses. It also helps regulate those muscle contractions and relaxation. Don't forget the heart is a big muscle. It also helps control the bones and teeth growth. It's absorbed from foods through the GI tract and vitamin D. It can be lost through both the urine and feces. Food sources include milk, milk products, dried beans, green leafy vegetables, small fish with bones, dried peas, and beans. It's primarily gotten rid of through the GI tract, a little bit through the kidneys, and it's regulated by that parathyroid gland hormone, and calcitonin. Also, don't forget that calcium and phosphorus have an inverse role. So if calcium is going up, phosphorus is going down, and vice versa. It can also help with B12 absorption. Magnesium is our second most abundant intracellular fluid. All right, and normal concentration for that is 1.3 to 2.3. Now, specifically with these two, if our calcium is too low, our body is going to have twitching and highly reactive deep tendon reflexes, okay, things like that. If we're too much calcium, then we're going to be sedated, sleepy, depressed deep tendon reflexes, everything's going to be slowed down. The same thing with magnesium. If it's too much, we're going to start to become toxic. Our blood pressure is going to start to decrease. Okay, we're going to become sleepy, drowsy, deep tendon reflexes decreased. Okay, if it's not enough, then our blood pressure is going to be up. Things are going to be twitchy, hyperactive. All right. So also, what does this magnesium do? It helps to metabolize carbohydrates and proteins. It helps with neuromuscular function, and then it acts on the cardiovascular system, producing vasodilation. Hence, when we have too much, it can lower our blood pressure. Okay, so it comes in the body through the GI tract in foods like green leafy vegetables, nuts, seafood, whole grains, dried peas, cocoa. It's lost through the urine with things like loop diuretics, and it's also eliminated by the kidneys and regulated by the parathyroid hormone. And then chloride. Okay, this is a major component of the interstitial and lymph fluid. Its function in the body is to act with sodium to help maintain the osmotic pressure. It also combines with hydrogen ions to produce hydrochloric acid. All right, it comes in the body through the GI tract, and almost all chloride comes from salt or foods that are high in salt. It normally works with sodium, and it's excreted, also conserved by the kidneys. It's regulated by aldosterone, and low potassium can affect the chloride levels. And then bicarb. This helps regulate the acid-base balance. It's a buffer in the body. Okay, it's in both the extracellular and intracellular fluid. Normal levels are, according to your author, 25 to 29. You might see those vary anywhere from 22 to 28. Okay. Losses are usually through diarrhea, diuretics, renal insufficiency, and then excess, okay, from over ingestion of things like Tums, acid neutralizers. So Tums, Rolaids, things like that, okay? And then the levels are regulated by the kidneys. So the kidneys are regulating those bicarb levels. The bicarb is readily available as a result of carbon dioxide, which is formed during metabolism. And then phosphate. Phosphate is another buffer, okay, and it acts as a hydrogen buffer. It helps promote energy. It helps store carbohydrates, fats, and proteins. It also helps with the it helps store energy. It helps store, and it helps with the metabolism. It also helps with forming the bones and the teeth, and it helps to regulate red blood cell production, and it also helps with muscle function. So it comes in the body through GI tract. It comes from animal products, mostly meat, poultry, eggs, milk, ready-to-eat cereals. Absorption is diminished by other ingestion of calcium. I'm sorry, by oral ingestion of calcium. Also magnesium and aluminum. So you have to be careful if you're giving this with, people that have like osteoporosis and they're getting products for that, then you would want to separate, these two. And remember that phosphate and calcium have that inverse relationship. One goes up, the other one goes down. Okay, it's eliminated mostly by the kidneys and regulated by the parathyroid hormone and activated by vitamin D. All right, so is the following statement true or false? Molecules are in the body's chemical compounds that remain intact are called electrolytes. True or false? Molecules in the body's chemical compounds that remain intact are called electrolytes. Okay, we know that's false, right? They're called non-electrolytes like urea and glucose. Okay, our electrolytes do not remain intact. They are particles that break down. All right, and they create these positive or negative anions and cations. All right, so now we're going to talk about how that fluid is transported throughout the body. Because our cells are what we call semi-permeable membranes, they allow some of these solutes like sodium, potassium, magnesium to pass through the cell membrane. But it's not permeable to everything. Okay, so osmosis is the process that allows this to happen. Now, the cell membrane does allow water or fluid to pass through it, okay, and that water shift or fluid helps with different solutes to be moved back and forth, or for the concentration to be equalized out. Okay, so when we use something called osmosis, this is where water, which is our solvent, it passes from an area of less solute concentration, and it goes to an area of greater solute concentration, and it does this to equal everything out. Okay, so as a result, the volume of the more concentrated solution increases, and the volume of the weaker solution is going to decrease. So osmosis will stop when the concentration of both sides is equal, okay, on both sides of the membrane. So the greater the difference in the concentration on each side, the greater that osmotic pressure or that drawing power is going to be. So that drawing power is referred to as osmolarity of a solution. Now, plasma or blood has an osmolarity between 275 and 295. And any solution that has that same osmolarity is considered an isotonic solution. And the reason why is because isotonic solutions are solutions that when we put them somewhere, they stay there. So if our concentration of our solution is the same as our blood, then it won't create this osmotic draw, because the osmotic draw is created when one of our solutions has a greater concentration than the other. So for example, if our blood had a concentration of 295 and we gave a solution of 350, okay, it's going to create that draw, because now we have a solution that's greater than the solution where we're putting it into. All right, so an isotonic solution stays where we put it. If we put let's say normal saline in the bloodstream because our patient is dehydrated, they don't have enough blood in that vascular space, okay, it's going to stay where we put it. It's going to stay in that bloodstream. Now, if we give a hypertonic solution, okay, that has a greater osmolality than plasma or blood. So that hypertonic solution, if we put it in the blood, it's going to cause the fluids that are in that cell, all right, to shift into the bloodstream, because the bloodstream has a greater concentration now. So it's going to pull from the cells into the bloodstream and cause those cells to shrink. Now, if we put something less concentrated in the blood, a hypotonic solution, okay, of less than 275, then it's going to cause that fluid to move from the bloodstream into the cell and shift. And it could cause that cell to swell if we gave it too much. Electrolytes also have an osmotic potential. Okay, so sodium has a very high osmotic potential. All right, and so it can cause, a certain type of pulling power as well. Now, in diffusion, instead of the solvent or the water moving, the solutes actually move freely throughout the solvent. Okay, and these solutes move from an area of higher concentration to an area of lower concentration called downhill until equilibrium is established. Gases also move by diffusion, so that's how carbon dioxide and oxygen exchange in the alveoli and capillaries, is through diffusion. Active transport requires energy. Okay, so that allows movement of substance through a cell membrane against what we call the concentration gradient. So it goes from an area of less concentration to an area of higher concentration, and it requires ATP. That's that energy that's stored in the cell, if you remember from back in the beginning of nursing school. Okay, so it helps using something called the sodium-potassium pump, all right, to move from that area across that concentration gradient. So when it's moving across that concentration gradient, it's actually moving kind of like uphill against gravity, okay? And some substances that are believed to use that type of transport, that active type of transport, are amino acids, glucose in some places, sodium, potassium, hydrogen, and calcium. Capillary filtration, this is the movement of fluid through that permeable membrane, and it moves from an area of high pressure to an area of low pressure. Capillary filtration is caused by the blood pushing against the wall of the capillary. And at the end of the capillaries, we have this arterial blood pressure. Okay, and filtration is dependent upon what that blood pressure is. So this pushing force is called hydrostatic pressure, and this is when the pressure inside the capillary is greater than that of the interstitial space that surrounds it. So the fluids and the solutes are basically forced out of that capillary wall and into that interstitial space. When the pressure inside the capillary is less than the pressure in the interstitial space surrounding it, then the same thing occurs. Okay, the pressure forces the fluids and the solutes back into the capillary. Reabsorption is a process that acts to prevent too much fluid from leaving the capillaries, regardless of how much force that is present. And this is important, okay, because it has proteins there called albumin, and what albumin is like a water magnet, okay? So it helps to facilitate the reabsorption process by pulling the fluid back into the capillaries. And so that pulling force is known as colloid osmotic pressure or oncotic pressure. So this hydrostatic pressure can exceed the colloid pressure. And at the end of the capillary, okay, you'll have less plasma colloid pressure than hydrostatic pressure. So we have this capillary filtration occurring, all right, and then it happens on the first half, and then along the second half is the reabsorption. So the combination of those two together is what is going to help regulate the pressure. All right, so the pressure is the difference between the filtration pressure is the difference between the colloid osmotic pressure and the blood hydrostatic pressure. You know, it's important for you to know about these pressures, how they leave, okay, and return, because this is how the kidneys actually filtrate in the glomeruli, all right? So we did talk briefly about the osmolarity of a solution. Remember, isotonic has the same concentration as the plasma, which is 275 to 295. So when we give an isotonic fluid, it's going to stay where we put it. Hypertonic fluid has a greater concentration, okay, than the plasma. So it's going to be greater than that 295. And so that's going to pull fluid from the cell into the bloodstream. All right, and when it does that, it has a risk of shrinking those cells. Hypotonic solution is lesser concentration, so it's going to be less than 275. Okay, and when we give a hypotonic solution, all right, it causes the fluid to leave the vascular space and go into the cell, and it can cause the cell to swell. All right, so that's the basic thing about those solutions. So remember the colloid osmotic pressure, that's the pressure exerted by those plasma proteins on the permeable membranes in the body. Okay, it's a pulling force, remember that. All right, and it's helping with filtration. All right, hydrostatic pressure, okay, that is the pushing force, and that is when that force exceeds in the capillary. Okay, so the force in the capillary exceeds that force in those surrounding tissues, and so fluid is forced out of those or pushed out of those capillary areas. Sources of food for the body, so we can, fluids for the body, we can get fluid from a lot of different ways, mainly ingesting food, and through byproducts of metabolism. And remember that fluid is lost through the kidneys in urine, through feces, through skin, perspiration. We have sensible versus insensible. Insensible losses are going to be things like perspiration and respiratory and feces. We can't measure the amount of fluid that we excrete in those areas. Fluid intake and losses. Okay, so in intake wise, through ingestion of water, we take about 1,300 mLs. Through food, about 1,000, and then through oxidation, about 300. And in total, about 2,600 mLs a day. And then output should equal, similar to that, about 1,500 through the kidneys, 600 through the skin, 300 through respiratory, and then 200 in GI. So that gives us about 2,600 total. What regulates what organs regulate and provide homeostasis to us with regards to fluid regulation? So, we have the kidneys. They regulate the extracellular fluid and the body's osmolarity, okay, through a process called reabsorption and filtration. So they selectively determine what they're going to keep and what they're going to rid the body of. They help regulate the electrolyte levels, okay, in the extracellular fluid, the pH in the extracellular fluid. Also, they excrete the metabolic waste, mostly acids, any toxic substances, and they filter about 180 liters of plasma daily in the adult, while excreting only about 1.5 liters of urine. The cardiovascular system, this pumps and carries the nutrients and the water in the body. It circulates that blood through the kidneys under pressure, okay, to make that urine form. And then it reacts to situations where we don't have enough fluid in the body, hypovolemia, okay, by stimulating fluid retention. Now, we talked about this. It can do this through receptors in the atria and blood vessels as well. So we have something called atrial natriuretic peptide and brain natriuretic peptide. And these two things can control water in the body. Now, BMP we generally see in a patient in regards to heart failure. So when the body is in fluid overload and those ventricles are really stretched, okay, the body is going to produce something called BMP. And elevations in that let us know how bad our patient is in regards to heart failure. Something called atrial natriuretic peptide is also released during the whole process of the renin angiotensin aldosterone system. Okay, so in response to our atrium having extra fluid in it, it releases something called atrial natriuretic peptide, and this atrial natriuretic peptide can help regulate how much fluid is in the body as well. The lungs, they help to remove about 300 mLs of fluid a day through exhalation. This is called insensible fluid loss. And also it gets rid of hydrogen ions as opposed to the kidney, which only gets rid of about 40 to 80 hydrogen ions. The lungs get rid of about 13,000. The lungs also help correct metabolic acid-base imbalances, regulate hydrogen ion concentration to help regulate the pH by controlling the level of carbon dioxide in the extracellular fluid. The adrenal glands, they help regulate the blood volume and also sodium and potassium by secreting something called aldosterone. This is a steroid that's secreted by the adrenal cortex, and it causes both sodium and water retention, okay, and potassium loss. Now, remember we talked about ADH, and I said that only controls water flow, but the adrenal glands actually control both sodium, chloride, and water, and they also excrete potassium. Cortisol is also produced by the adrenal cortical hormone, and it has a little bit of the same qualities as aldosterone. All right, but it can help a little bit with sodium and water and potassium also issues. And then the pituitary gland, remember I said the posterior pituitary gland, or the PP gland, that releases ADH, the antidiuretic hormone, and that's going to mainly control water in the body. It also helps if the osmotic pressure of the extracellular fluid is greater than that of the cells, the ADH can be released, okay, causing the kidneys to retain water. If the osmotic pressure is less than that of the cells, like when we have hyponatremia, the ADH secretion could be decreased and cause the kidneys to release some of the water to balance things out. Okay, so ADH is released from that posterior pituitary gland to help control. The thyroid gland, that helps increase blood flow in the body by releasing something called thyroxine, and this causes an increase in kidney circulation and also an increased glomerular filtration and urinary output. The nervous system helps to regulate, okay, by influencing the fluid balance. It inhibits and stimulates different mechanisms in the body to regulate sodium, water excretion, and intake. It also regulates oral intake by triggering thirst, okay, and neurons called osmoreceptors help detect different changes in the concentration of the extracellular fluid. So these neurons will then send that impulse to the posterior pituitary gland to either release ADH or inhibit it. And then the GI tract, that helps us absorb water and nutrients that enter the body. The parathyroid glands, these regulate both calcium and phosphate. And they do this through release or inhibition of the parathyroid hormone. Okay, if we release it, it's going to cause elevated levels of serum calcium, and it's going to lower the phosphate level. If we inhibit the secretion of the parathyroid hormone, then we'll see a lower calcium concentration and a high phosphate level. All right, so the parathyroid influences both bone reabsorption, calcium reabsorption from the intestines, and calcium reabsorption from the kidney in the renal tubules as well. Tell whether the following statement is true or false. A hypertonic solution has a greater osmolarity, causing water to move out of the cell and be drawn into the intravascular compartment, causing the cell to shrink. True or false? A hypertonic solution has a greater osmolarity, causing the water to move out of the cell and be drawn into the intravascular compartment, causing the cell to shrink. Okay, that's true. All right, hypertonic solutions have the greater osmolarity to cause water to move out of the cell and into the intravascular compartment, and this can cause the cell to shrink. So the body also has to maintain its acid-base balance, okay, and certain chemical reactions constantly occur in the body that affects this metabolism and the function of the body system. These chemical reactions depend on the balance of the acid and the bases, and some conditions like infection or trauma can alter the acid-base balance. For example, if we had some kind of trauma like a crushing injury or a burn, that could cause fluids to leak out of the cell and into the body and affect that acid-base imbalance. Okay, so also infections, okay, so that can affect it also. So an acid is actually a substance that has something in it called hydrogen ions, and they can be liberated or released as a carbonic acid. Now, and a base is a substance that accepts or grabs these hydrogen ions like a bicarb ion. So as acid releases the hydrogen ion, okay, the H2CO3 or the carbonic acid releases the hydrogen ion, and it forms a bicarbonate base. Okay, and as the base traps hydrogen ion as follows. Okay, the bicarb will trap the hydrogen ion, and when it does that, then it forms something called carbonic acid, H2CO3. So a strong acid will separate in a solution and release all of its hydrogen ions, but a weak acid will only release a few. A base that easily accepts a hydrogen ion is considered a strong base, whereas one that doesn't accept those hydrogen ions as easily is considered a weak base. pH is used to describe the acid-base balance, and it tells us what the hydrogen ion concentration is and whether it's acidic or whether it's alkalinic. Okay, so it ranges from anywhere from 1 to 14. A neutral solution measures at 7. So an example would be pure water. Okay, when the concentration of those hydrogen ions in a solution is reduced or accepted by another substance, and the solution contains more base than acid, then it's considered alkalinic. If it gets more acid than alkaline, then it's considered acidic. So our normal pH is a little bit alkaline, with the range being from 7.35 to 7.45, with 7.4 being the optimal range. Okay, and whenever the pH exceeds that normal range in either direction, then the person can present with signs and symptoms of illness. Okay, and if it goes unattended to, then it could result in death. Acidosis means we have too many hydrogen ions, or we've lost too much bicarb or too much base. The extracellular fluid pH is going to go below 7.35. In alkalosis, we don't have enough hydrogen ions, or we have too much base. Okay, and the pH is going to go above 7.45. Okay, so you want to know, what are those ranges? Look at page 40-8, and that will tell you the ranges at which death normally occurs when that pH is off. So there's a few things in the body that help regulate the normal pH through the hydrogen ions, and these are called chemical buffer system, respiratory mechanism, and the renal mechanism. So basically, it's our buffer system, our lungs, and our kidneys. Okay, so when we have alterations in these areas, like either we're too young and our lungs aren't developed, okay, or we're old and we have some sort of lung disease, then it's going to affect our ability to manage and control. Okay, so those are things that we have to take into consideration. Now, a buffer itself is just a substance in the body, and it keeps the body from becoming too acidic or too alkaline. So they'll either combine with the excessive acids or the excessive bases, and they'll change or prevent changes in the pH, okay, to try to keep the pH in control. And as close to that range of 7.35 to 7.45 as it can. So the buffer can either act like a base and soak up the free hydrogen ions, or it can act like an acid and release hydrogen ions if there's not enough present. All right, so the body has 3 buffer systems: the carbonic acid sodium bicarb buffer system, the phosphate buffer system, and the protein buffer system. So carbonic acid is the most common acid in the body, and the most common base is bicarb. All right, so normal extracellular fluid has 20 parts bicarb to 1 part of carbonic acid. And when it's in those ranges, then it's pretty much controlled or within the normal range of what we want it to be. The lungs help regulate carbonic acid, okay, from a combination of carbon dioxide and water. So they combine together and they form this carbonic acid. Also, carbonic acid regulating the production of the bicarb. The phosphate buffer system, okay, that's active in intracellular fluid, especially in the kidneys, in the renal tubules, and it converts the alkaline sodium phosphate, which is a weak base, to an acid sodium phosphate in the kidneys. And then the protein buffer system, this has plasma proteins and hemoglobin in the red blood cells, and because of the plasma proteins and the hemoglobin, the chemical cells combine with those hydrogen ions, okay, and they help prevent changes or minimize changes in the pH. So they buffer against a potential wide range of pH values by working both in and out of the cells. So hydrogen ions, when they're excess in the blood, they will cross the plasma membrane of the red blood cells and bind with the hemoglobin that are plentiful in the red blood cells. Due to the huge surface area from which carbon dioxide can diffuse, the lungs can bring about rapid changes in the hydrogen ions when they need to. All right, so they're going to do this by metabolism and excreting it through exhalation. So the amount of carbon dioxide in the blood, if it increases, okay, chemoreceptors in the respiratory center in the medulla are going to stimulate the lungs to increase the rate and the depth of respiration to allow us to eliminate that excess carbon dioxide. And as it's exhaled, the bicarb level in the blood will decrease and the blood will become more alkaline. If the blood level of the carbon dioxide decreases, then the respiratory center will decrease the rate and depth of the respiration to help retain the carbon dioxide so that carbonic acid can be formed and maintain the balance. So the lungs are the primary controller of the blood's carbonic oxygen supply. Now, why the lungs can act rapidly, okay, it's a short-term response. So the kidneys will additionally be needed if some sort of long-term adjustment is required for these patients. Now, also the kidneys, they help excrete or retain hydrogen ions to form or excrete bicarb ions and help form or excrete bicarb ions, okay, in response to that pH of the blood. So if we're acidotic, the kidneys will excrete hydrogen ions and form and conserve the bicarb ions, and that's going to help raise the pH to the normal range. If alkalosis is occurring, then the kidneys will reabsorb or retain these hydrogen ions and excrete bicarb to try to return the body back to homeostasis. As a result, the bicarb in the plasma is regulated by the kidneys, okay, through this concentration. So acid-base regulation by the kidneys is slower than that of the lungs, okay. Whereas we talked about earlier with the lungs, it's going to happen right away. With the kidneys, this regulation could take as long as 3 days for the pH to be restored. All right. So which of the following chemical buffer systems is the most important buffer system in the body that buffers as much as 90% of the hydrogen of extracellular fluid? Carbonic acid sodium bicarb buffer system. This buffer carb system, okay, is the most important buffer system in the body, buffering as much as 90% of hydrogen of extracellular fluid. Buffers attempt to bring the body fluid as close to possible to the pH of normal body fluid of 7.35 to 7.45. So fluid imbalances occur when the body's compensatory mechanisms are no longer able to maintain homeostasis. Okay, and this doesn't just affect something that, with the kidneys not working, the hypothalamus might not be working, the posterior pituitary gland might not be working right, the adrenal glands. So, there's a number of different things in the body, organs, glands, signals that are sent throughout the body that help control this fluid imbalance. So, it could be one or a number of things that are not working correctly that are causing this imbalance to occur. All right, so it's either going to involve the volume of the fluid or the distribution of water or electrolytes. So as nurses, we have to think about things like risk factors. What kind of nursing assessment are we going to do on this patient? What kind of interventions do they need? With fluid volume deficit, this is generally caused by a loss of water and solutes, and we lose them in the same amount from the extracellular space. So it's called hypovolemia or isotonic because it's lost in the same amount. This can cause changes, okay, in the intravascular space, okay, where the body tries to compensate for the loss of the volume in the blood vessels. So as the interstitial space is depleted of volume, the fluid becomes hypertonic, okay, and then cellular fluid is drawn into that area, and that causes the cells to be left without adequate fluid, and then they can't function properly. So the volume deficit is caused by the loss of body fluids usually, and in also response to the loss of body fluids, for some reason, instead of increasing the fluid intake, we're often decreasing that fluid intake. So the combination of the decrease in the fluid intake and the loss of the body fluid leads to this dehydration. Now, patients that are most at risk for it are going to be infants or young children, older adults, and people who are already ill are at risk for hypovolemia as well. Okay, some other people that you might see with an issue or risk for this is somebody that has something like diabetes insipidus. Okay, so this deficit will be seen through a few ways. One of them is weight loss. Okay, so weight loss of 5% in adults or 10% in infants. Weight loss of 5% or greater is considered a pronounced fluid deficit. 8% or more is considered severe, and 15% or more can actually be life-threatening. So you want to be careful when your patients are in this fluid volume deficit. Some other things that you might see are, sunken fontanelles in an infant, sunken eyes, that could be an adult or infant, lack of elasticity in the skin, so it might be tenting, what we call a tenting effect to it, and you would be checking that like over the sternum and the forehead of the patient, okay? And then you might be looking at some lab values and stuff like that as well. Third shifting, this is when we have too much fluid, but it's not in a place when we need it. So we would like the fluid to be in the cell or in the vascular space, but with this, what happens is the fluid goes to an area where we can't use it, like the pleural space or the peritoneal space, like we see in ascites, in pericardial areas, in joint cavities, sometimes the bowel, or sometimes in the interstitial spaces. So we'll see that as like edema in the legs, the feet, and those areas that where that gravity pulls the fluid to. Okay, so once it gets in those spaces, we really can't use it. There's two problems with that. Number one, we now have this extra fluid in a space that we can't use it, that can cause us potential problems. And two, sometimes that in itself, that third spacing of the fluid, can lead to dehydration, because even though the patient has this fluid in the body, it again is in a place where they can't use it. All right, so it's trapped in these body spaces for time, and it's not available for use, and this causes a disruption, okay, in the way the cells and everything function. All right, so the fluid shift could be caused by things like the colloid osmotic pressure. Maybe the patient doesn't have enough albumin in their system. They could have an increase in fluid volume because maybe we were giving them fluid volume replacement, like IV fluids, or we were just giving them IV fluids for something else, and we gave them too much, and the body didn't, distribute it the way it should have. Maybe they have kidney function. Maybe they're in heart failure. Okay, or maybe they have hyponatremia. Okay, or maybe they have some kind of tissue trauma. All right. But either way, this third spacing is happening. The third spacing can also occur as a result from burns, bowel obstruction, surgery, pancreatitis, ascites, or sepsis. All right. And then we don't see a decrease in the body weight as it happens with extracellular volume. Okay. And the fluid volume loss cannot be measured. So in fluid volume excess, we have too much water and sodium in the extracellular fluid, okay, and they're close to being equal in volume, all right, and it could be from this excess sodium and water intake, and also it could be from, the things that are supposed to be controlling the fluid and the volume aren't working. All right, so common causes are the kidneys not functioning correctly, or they can't excrete the excess. Maybe the heart isn't pumping the way it should be, and so we have this excess fluid in the lungs or other parts of the body, like the legs and stuff, because they like to accumulate there because of the gravity. All right. We have an increase in the extracellular osmotic pressure because we're retaining sodium and water. Okay. And that is because the body is pulling the fluid from the cells, trying to equalize or trying to make the tonicity the same. All right. And tonicity is the amount of solutes that is in that water. So it's trying to equal them out. All right. So we have an excess of both water and sodium. All right. And the cells, and that's in the extracellular fluid, but in the cells, we don't have anything hardly. It's almost depleted. So the excessive extracellular fluid will accumulate either in the intravascular compartment, and we'll have something hypervolemia. So our, too much fluid in our body. Okay, or it might go even into the interstitial spaces. Now, if it goes into the bloodstream, or the vascular area, we're gonna refer to it as hypervolemia. When it goes into the interstitial areas, then we refer to it as edema. And that edema, it can happen throughout the body, the eyes, the fingers, the ankles, and we really have to watch the sacral space, especially if our patients are lying in bed a lot, okay? It also can accumulate around other organs inside the body. The fluid can cause a weight gain, usually one that is going to be greater than 5%, okay? And the severity of the edema is graded, all right? So we look at whether it's pitting, non-pitting, and how deep it is. Okay, interstitial to plasma shift is the movement of fluid from the space around the cells to the blood. And as the body tries to maintain balance, okay, the intravascular space is going to be protected at the expense of the interstitial fluid and the intracellular fluid. So if the body has to pull it somewhere, it's going to pull it to that vascular space first if it can, okay? And it's not going to care about the other areas because it's, again, trying to protect and maintain balance in what the body feels is the most appropriate area. Now, overhydration, this is when we have too much fluid in the extracellular space. All right, so we don't want that. So now we're going to talk about the different electrolyte imbalances. The first one we're going to talk about is hyponatremia. Okay, remember sodium levels want to be between 135 and 145, so this is going to happen if our sodium level is below 135. Okay, when we talk about hyponatremia, we're talking about sodium levels in the extracellular fluid. All right, and so in that extracellular fluid, we've lost sodium or we've gained too much water. And we can do this through vomiting, diarrhea, sweating, diuretics. Okay, so we lose this sodium, and that causes a fluid shift by osmosis. So we have less sodium in the extracellular fluid, and so that's going to cause the fluid to shift from the extracellular fluid to the intracellular fluid, and that's going to cause the cells in the intracellular fluid to swell. Okay, and as a result, the patient's going to have neurological issues. Okay, so they're going to have confusion. They can be at risk for hypotension, edema, muscle cramps and weaknesses, and dry skin. Severe hyponatremia is seen by signs of increasing intracranial pressure, and that can cause lethargy, muscle twitching, weakness, hemiparesis, and seizures, and the person could even die. Now, with hypernatremia, this is when we have too much sodium in the extracellular fluid, so our sodium level would be greater than 145. This can be caused by excessive fluid or water loss or by an excess of sodium. So if we deprive ourselves of fluids by not taking in enough, or we deprive the patient of fluids because maybe they're comatose or they can't speak or communicate, okay, we can cause this in the patient. Other things that could cause this would be diarrhea or some kind of excess insensible fluid loss like hyperventilation, or sometimes trauma to the cells like a burn or excessive burns, okay. Also, this can cause a fluid shift. All right, so now this can cause the fluid to move from the cell, okay, into the extracellular space, and it causes the cell to shrink and leaves them without enough fluid. And remember, when the cell doesn't have enough fluid, it doesn't function correctly. So it's going to impair the function of the central nervous system. Neurologically, it's going to impair the patient. It could cause manifestations such as restlessness, weakness, disorientation, delusion, and hallucinations. And also permanent brain damage can occur. So when you think about sodium levels, think neuro and think seizures. Your patients are at risk for seizures. All right, potassium. Potassium is a major intracellular electrolyte. When we talk about hypokalemia, it talks about potassium deficits in the extracellular fluid. Remember, potassium is going to be 3.5 to 5.0, so if it's less than 3.5, all right, and it's also lost through things like vomiting, gastric suctioning, alkalosis, diarrhea, and diuretics. When those potassium levels fall, this causes potassium to move from inside the cell, causing a deficit there, to outside of the cell into the extracellular fluid. So the sodium and the hydrogen ions are then retained by the cell to try to maintain homeostasis. All right, so those electrolyte shifts affect the ability of the cell to function normally. It affects the pH of the extracellular fluid and the function of most body systems, particularly cardiovascular. The skeletal muscles are the first to show this potassium deficit. So, what does that do? The skeletal muscle, it returns blood flow back, helps return blood flow back to the heart, does a few things, right? So, for hypokalemia, you're going to see muscle weakness, leg cramps, fatigue, because leg cramps, the skeletal muscles are located down there, fatigue, paresthesias, and then eventually dysrhythmias, because it is going to affect the heart. It is a muscle. All right. Hyperkalemia is this excess of potassium in the extracellular fluid. So potassium levels of greater than 5. And this is because for sometimes it's because of kidney failure. All right. The kidneys can't excrete the potassium, and they're responsible for excreting it. But if they're not working properly, hypoaldosteronism, use of certain medications like potassium chloride, heparin, angiotensin converting enzymes or ACE inhibitors, NSAIDs, and potassium sparing diuretics. This happens less often than hypokalemia, but it can be a lot more dangerous. So it also affects nerve conduction and muscle contractility. It causes skeletal muscle weakness. Remember, those are in those legs. They help pump the blood back to the heart. It can cause paralysis and also cardiac irregularities, including cardiac arrest. Hypocalcemia and hypercalcemia. So calcium is used majorly for the bones and the teeth, but it also has a lot to do with muscle contractions. Okay, not enough calcium is generally less than 8.9. Okay. Remember, your levels are going to be like 8.9 to 10.1. Some books you'll see 9 to 11. Okay. Common causes for these calcium deficits are not enough. We don't take enough in. We're not absorbing it well enough, or we're losing it for some reason. Now, what are you going to see in these patients? So you're going to see more hyperexcitability if they're hypo. So if they don't have enough, you're going to see things like numbness and tingling of the fingers, the feet, tetany, which is twitching of the muscles, muscle cramps, and seizures. Hypercalcemia refers to an excess amount of calcium in the extracellular fluid, so you're going to see greater than 10.1. Major causes are cancer and hyperparathyroidism, and so then with these patients, they're going to be sluggish, sleepy, lethargic, slurred speech. Things are going to be decreased deep tendon reflexes. They may have nausea, vomiting, bone pain, moans, bones, and groans you'll hear with these people. So kidney stones, excessive urination. All right, severe hypercalcemia is an emergency situation because cardiac arrest can occur. So, with these kind of patients, you have to encourage fluid to try to get rid of some of that calcium in the body. And then we have magnesium. Okay, magnesium is similar to calcium. When we have too much magnesium, it's going to sedate us, decrease our deep tendon reflexes, decrease our blood pressure. Not enough is going to have a little bit opposite effect, right? Increase, cause hyperactive deep tendon reflexes, tetany, seizures. Okay, so magnesium is one of the most abundant intracellular cations after potassium. Okay, hypo refers to less than 1.5. So your ranges are going to be 1.5 to 2.5. Loss can occur with nasogastric suctioning, diarrhea, alcohol withdrawal, tube feedings, parental nutrition, sepsis, or burns. So this abnormality, the hypomagnesium, is going to cause muscle weakness, but tremors, tetany, seizures, heart block, changes in mental status, hyperactive deep tendon reflexes, and respiratory paralysis. Too much magnesium, okay, is excess in the extracellular fluid. So we're going to have too much magnesium, and it's going to happen with kidney failure. The kidneys aren't going to excrete the magnesium, or maybe the person took too much magnesium in, like through some sort of magnesium-containing antacid or a laxative. And so we have these manifestations of nausea, vomiting, weakness, flushing. We don't have those deep tendon reflexes. They're diminished. Respiratory depression, coma, and cardiac arrest. Hypophosphatemia and hyperphosphatemia. So remember, with phosphorus, this is has an inverse reaction with calcium. So if our phosphorus is low, then we should check our calcium because it could be high. Same thing with hypokalemia. It's not an inverse relationship, but if If our potassium is low, we might want to take a look at our chloride. All right, so hypophosphatemia and hyperphosphatemia. So low phosphorus levels are going to be less than 2.5. Okay, and if it's elevated, it would be greater than 4.5. So this helps with body tissue. And it can be caused, the low phosphorus level can be caused by administration of calories to malnourished patients, alcohol withdrawal, diabetic ketoacidosis, hyperventilating, release of insulin, absorption problems, or diuretic use. And so these patients are going to be irritable, fatigued, they're going to have weakness, they may have paresthesias, confusion, seizures, and coma. Hyperphosphatemia is too much phosphorus, so greater than 4.5 in the extracellular fluid. And then this can be caused by poor kidney function, hypoparathyroidism, and also signs and symptoms for this are going to be like tetania, anorexia, nausea, muscle weakness, and tachycardia. And then hypochloremia and hyperchloremia. This is chloride levels. Okay, so chloride is the major anion, so without charge, negative charge in the extracellular fluid. Hypo refers to a level of chloride that is below 96, and hyper would be a level above 106. This can be caused by things like severe vomiting, diarrhea, draining gastric fluids, metabolic alkalosis, diuretics, burns. So with this, we'll see hyperexcitability. So remember hyperexcitability of the muscles, tetany, hyperactive deep tendon reflexes, weakness and muscle cramps. And then hyperchloremia, we're going to have that extracellular fluid greater than 106. It can happen from things like metabolic acidosis, head trauma, increased perspiration, excess adrenal cortical hormone production, or decreased glomerular filtration rates. Signs and symptoms include things like tachypnea, weakness, lethargy, diminished cognitive ability, hypertension, decreased cardiac output, cardiac arrhythmias, and coma. Which of the four electrolyte imbalances occurs due to a sodium deficit in extracellular fluid caused by a loss of sodium or a gain of water? So sodium deficit is equal to hyponatremia. All right, so this is a sodium deficit in the extracellular fluid. We either lost sodium or we gained water. So acid-base imbalances occur when we have either too much acid or not enough bicarb, or too much bicarb, not enough acid. So we have this unequal level of one or the other. And if there's a known single cause, then we would describe them as respiratory acidosis, respiratory alkalosis, or metabolic acidosis or metabolic alkalosis. Now, if it's referred to as respiratory, whether it's acidosis or alkalosis, the cause is some respiratory disturbance. And a respiratory disturbance is going to alter the carbonic acid level in the extracellular fluid, and that shows up on the ABG as PaCO2 level, or that carbon dioxide or carbon diacid, as I call it, level. When the body tries to compensate for this issue, okay, the lungs will try to either retain or eliminate that extra carbon diacid or carbon dioxide. So you might see this in something like diabetic ketoacidosis, where we have these deep, okay, irregular respirations, okay, as the body tries to eliminate some of that acid that's on it, okay, and the kidneys may also attempt to restore balance through conserving, forming, or excreting bicarb, all right, depending on whether it's acidosis or alkalosis. Respiratory acidosis is when we have too much acid, and it's usually caused by not excreting enough carbon dioxide or carbon diacid. So we see this when the person doesn't have adequate ventilation, and it causes them to retain CO2. Okay, so this could be caused by a decrease in alveolar ventilation, and instead of releasing the carbon dioxide, the person's retaining it, and that can cause respiratory acidosis. So you might see this if a person had something like weak respiratory muscles and they weren't taking like full deep breaths. They were hypoventilating, and that's causing them to retain that CO2. In the beginning, the increased amounts of the CO2 are going to send a message to the medulla, okay, in the brain, and that will cause the body to increase that respiratory rate. And then as the respiratory rate increases, the carbon dioxide or dioxide is released from the body, and it starts to decrease the carbon dioxide level. Okay, if that respiratory response doesn't work, if it's not effective, then the carbon dioxide levels that have increased will now stimulate the kidneys, and the kidneys will try to eliminate hydrogen ions or acids, and they'll try to hold on to bicarb and sodium ions. Okay, this system acts to buffer the free acids and eventually reduce the carbon dioxide levels and help restore the acid-base balance. So respiratory acidosis, or a high PaCO2, is generally due to hypoventilation or alveolar hypoventilation. So the alveolar of the lungs isn't ventilating as well as it should be, or it has a low ventilation problem. Excuse me. For respiratory alkalosis, okay, this is when we don't have enough acid in the extracellular fluid, and it's usually a result of hyperventilation or alveolar hyperventilation. In other words, we're breathing faster and deeper, and we're eliminating too much carbon dioxide. So that carbon dioxide loss causes a decrease in the levels of acid and an increase in the pH. So again, receptors in the medulla feel or sense this increase in the pH and the presence of not enough acid. So they start to stimulate the body to either breathe more slowly or less deeply. All right, and if it lasts 4 or 6 hours or longer, then the kidneys will start to try to alleviate the imbalance by increasing excretion of the bicarb and retaining more hydrogen so that it can correct the imbalance. So with respiratory alkalosis, you have a low PaCO2 or low carbon dioxide diacid level, and that's due to alveolar hyperventilation or hyperventilation. With metabolic acidosis, this is a non-respiratory acidosis, and it's due to a decrease in bicarb in the extracellular fluid, and it can be a result of too much acid or excessive loss of bicarb. So it can be produced by the body, like retaining hydrogen ions or losing bicarb. And in this case, the lungs are going to try to increase the amount of carbon dioxide or carbon diacid they're excreting. So we'll see an increase in the rate and the depth of the respirations. That should occur fairly quickly, but it won't last. If it fully compensates, then good. But if it doesn't, and generally it doesn't, then the kidneys are going to try to compensate by retaining bicarb and excreting more hydrogen. So in metabolic acidosis, we're going to have a low pH below 7.35, okay, and we're going to have an increase in hydrogen ion concentrations. We'll also have a low bicarb concentration because we've retained or gained these hydrogens or lost bicarb. Metabolic alkalosis is also a non-respiratory alkalosis, and it's associated with an excess of bicarb or a decrease in hydrogen ions or both in the extracellular fluid, and this can be from excessive acid loss or an increase in some sort of base ingestion or retention. So the body's trying to compensate, and it starts to retain carbon dioxide or carbon diacid. The respirations will become slower and more shallow. Okay, so we're excreting less carbon dioxide and retaining more. And then periods of apnea or no breathing may even occur. The kidneys will start to excrete excessive H2O and sodium ions with the excessive bicarb, and then try to hold on to those hydrogen ions. So metabolic alkalosis, we're going to have that high pH above 7.45, a high bicarb concentration, and this is from gaining bicarbs or from losing hydrogen ions. Now, we have to be aware of this as nurses because both acute and chronic illnesses, trauma, and other interventions can put a patient at high risk for fluid, electrolyte, or acid-base imbalances. And they can seriously compromise the patient's status and maybe even put them into a life-threatening condition. So you have to be able to identify patients that are at high risk, determine what kind of imbalance that they have. What kind of care would you give them based on that imbalance and other things associated with that imbalance, and then be able to evaluate how effective that care plan is. So we're going to be looking at that nursing history and how it relates to the fluid, electrolyte, or acid-base imbalance. This you would want to include the history, physical assessment. You might want to measure the patient's I-nose, daily weights, and look at their lab studies. If there is a fluid imbalance, we're looking at electrolytes, or if we think there's an acid-base balance, we need to know what kind of actual issue there is, so that we can put the right assessment into place. Okay, and if you look at table 40-3 in your book on page 15, 68, and 69, it goes through some of that. For a nursing history, you want to ask patients questions about their fluid and electrolyte and acid-base status. So you would want to do a focused assessment using interview questions to identify what their usual pattern of intake and output is, and how they evaluate their own hydration status, and if they're aware of problems that they may have. Also, you would want to look at risk factors. What kind of risk factors would you expect for a patient that has an imbalance? Okay, so risk factors might include chronic illness or acute illness like diabetes, congestive heart failure, kidney failure. Also, any abnormal losses of body fluid, so any prolonged or severe vomiting, diarrhea, bleeding, wounds, fistula, burns, trauma, any type of surgery, anything that may interfere with that fluid and electrolyte balance. And then what kind of therapy or medications, drugs would we have to consider? So things like diuretics, steroids, IV therapy, parenteral nutrition, those kind of things, because they all involve, distribution of fluids in some way. So, when we're looking at the overall assessment of that patient, we're looking at things like the skin turgor. How elastic is it? How's the moisture of those oral cavities? Do they have tears and salivation? What's the skin look like? What's the temperature of it? How's their face appear? Are there any sunken in areas or any puffiness, edema? Okay. What's the body temperature like? How's that pulse? Is it barely there, or is it full and bounding? And what about those respirations? Are they within normal limits? Are they taking full, deep respirations like they should be? And how's the blood pressure? So those are the kind of things that you're really looking at as the nurse. And daily weights. Why daily weights? Well, weight is a high indicator, especially quick weight gain or loss of fluid, because fat takes time to lose, but when we gain or lose quickly any large amount of fluid, we have to consider that most of the time as water loss, okay, or gain. And then lab studies. So we're looking at the electrolyte values like the sodium, the calcium, the potassium, the magnesium, the chloride, but we're also looking at things like the hematocrit, the hemoglobin, the BUN, the creatinine, because those are going to tell us things about kidney function and about the patient's hydration status. So some labs that we would be looking at are like a CBC, okay, because if our hematocrit was increased, we would know that our patient could be in a fluid volume deficit and possible shock or headed towards a shock state. Because when we lose fluids, okay, our levels become what we call hemoconcentrated. All right, so we would have decreased hematocrit values if we had some sort of massive blood loss or a quick or acute blood loss, or if we had a hemolytic reaction after a transfusion, or with fluid volume overload. With hemoglobin, we would see that increased if we had hemoconcentration of the blood. And we would see it decreased in states where we have anemia or hemorrhage or after a hemolytic reaction. We're also looking at levels of sodium, potassium, calcium, magnesium, phosphate, and chloride to see if they're below or above normal. Also, our bicarb ions, okay, and BUN. So we would see an increased BUN if the patient had impaired renal function or some issue like shock, heart failure, salt, and water depletion, diabetic ketoacidosis, or burns. We would see an increase in creatinine also in someone that has impaired renal function, heart failure, shock, or dehydration. We would also want to look at things like urine pH and specific gravity. So a low urine volume and high specific gravity could indicate a fluid volume deficit. A low urine output and a low specific gravity could indicate some kind of kidney disease. High urine output suggests fluid volume excess, and hypovolemia causes a decrease in renal perfusion and a low urine output. All right. Also, increased urine volume if the kidneys are functioning normally for hypervolemia. Some other issues that can affect our urinary output are the amount of fluid that we take in, how much we actually lose through the skin and other areas of the body, our blood volume, and our aldosterone and antidiuretic hormone. Normal urinary output should be about 1,500 mLs over a 24-hour period. Okay, and the range of specific gravity is from 1.003 to 1.035. So urine osmolarity itself is going to range between 500 and 800 osmos per kilogram. So we're also looking at body weight because a lot of people don't record the INO accurately, and body weight is one of the most accurate indicators of fluid loss and gain. So we definitely want to take a look at that. If patient is their dry weight, it should be pretty stable. All right, so we're looking at any rapid weight gain that happens, and we're looking at a loss or a gain of 2.2 pounds. That's equal to about a liter of fluid. Now, the urine pH, that should be somewhere between 4.6 and 8.2. If it's low, that can happen with metabolic acidosis, diabetic ketoacidosis, diarrhea. High pH levels can occur with alkalosis, low potassium levels, and kidney failure. And then we already talked about the specific gravity. ABGs, those are also some lab tests that we would look at that would tell us about the oxygenation and ventilation as well as what kind of treatment we might need based on the imbalance that we find. So we would do that through an ABG sample. Before you do that, you want to do something called an Allen's test, and that is going to really determine the adequacy or the patency of the vessel. So the pH is going to tell us whether it's acidosis or alkalosis. Okay, and then we're looking also at the PCO2 level and the bicarb level. So we talked about this a little bit before. Okay, partial pressure of the gas, okay, is used to reflect the chemical or the physical activity of the gas. So it's abbreviated as PaCO2 for carbon dioxide, and for oxygen it's PaO2. And the A represents that it came from the artery. Okay, so that's that test I'm talking about. We do the Allen's test before we go into the artery to get that blood specimen. All right, if the PaO2 is low, hemoglobin is carrying less than the normal amount of oxygen, and when it's high, the hemoglobin is carrying more oxygen. When the PaCO2 is red, okay, it's reading the respiratory activity. So if it's low, then carbonic acid is leaving the body in high amounts, or carbon dioxide. Okay, when the PaCO2 is high, then the body is retaining excessive amounts of that carbon dioxide or that carbon diacid. So O2 sats reveal the percentage of oxygen in the blood that combines with the hemoglobin. The bicarb level tells us what the bicarb level is in the body, and the kidneys help to either reabsorb the bicarb or excrete it. So that just depends on what the body needs in order to maintain that balance. The body uses compensation to restore balance. Sometimes other corrections may be required, okay, and this could be both medical and nursing interventions like ventilation, mechanical ventilation, monitoring INOs, dietary teaching. We might have to give some sort of medications or fluids. So, it really just depends on what's going on with the patient at the moment. So when you're doing ABGs, okay, one thing, you can go on to two sites. RN.com, I believe, is the one site on YouTube, and she does tic-tac-toe for ABGs. It's a real easy way. And also Nurse Karma with a K. She does a nice tic-tac-toe method and will really break it down for you on how to determine whether it's, alkalotic, acidotic, respiratory, or metabolic. Okay. Risk factors for imbalances include what the cause is. Okay, what's causing? Do we have some acute or chronic illness? Okay, did we have some sort of abnormal loss of body fluids? Did we have burns? Or is our issue trauma? Have we had surgery? Or are we engaged with some sort of therapy that's causing an issue with the fluid and electrolyte imbalance? So, those are things that we are going to want to know first in order to treat the patient. These are some nursing diagnoses that are related: excessive fluid volume, deficient fluid volume, and risk for deficient fluid volume. So we talked about excessive fluid volume. That can be from patients that are either receiving some sort of fluid intake, like IV fluids, people that have kidney failure, heart failure, so they're not excreting the appropriate amount of fluid. And then fluid volume deficits that can occur from either not taking in enough fluids or some kind of fluid shift, some kind of bleed. Also, fluid and electrolyte issues can be related to things like strenuous exercise, extreme heat or dryness, conditions that increase our metabolic rate like fevers, Okay, all those things can play a part. What kind of outcomes do we want for these patients? So these are derived from the actual or potential issue. Okay, so what's happening with our patient? And that's going to be based on what our outcome is. So if our patient is in fluid volume overload, then we would want to decrease the fluid on the body. So there's a number of ways we could do that, right? We're going to monitor the INOs and maybe give the patient diuretics, depending on what's going on with the body. If it's a kidney issue, we might have to dialyze them. If it's a cardiac issue, we might have to give them diuretics. If it's a problem with the hypothalamus or the pituitary gland, then we would have to correct something there. So it really depends on, what's the reason. Are they having a bleed? We would have to stop the bleed and then restore the fluids. Okay, did they get burned? Did the fluid shift because of that? So that's how we're going to decide. We want to maintain that urine-specific gravity within normal range. Okay, and we're going to practice or teach the patient how to practice self-care behaviors so that they are taking in enough fluids so that they're maintaining their electrolyte and acid-base balance within normal limits, and to help them take in and put out the appropriate amount of fluids and electrolytes. And then also we want them to be aware of their body's signals and signs of impending fluid volume overload or deficit or some sort of electrolyte or acid-base imbalance. So, as the nurse, what type of interventions can we do to prevent or correct this fluid, electrolyte, and acid-base imbalance? And those kind of things are going to be teaching the patient how to modify the diet, okay, teaching them how to modify their fluid intake, proper medication administration if needed, IV therapy, administration of blood products and the replacement of blood, administration of parental nutrition if needed, reassuring the patient to help them deal with the anxiety, and teaching the patient and the family about their condition, how to recognize certain signs and symptoms, and what to do when those symptoms occur, as well as things to prevent. So for fluid and electrolyte imbalances, a nutritious diet, okay, adjustments throughout the life cycle to help promote fluid balance, and nurses need to be aware of what kind of measures that the patient should take to prevent these issues. So, for instance, if your patient has a fluid volume deficit, you're going to teach them foods with high water content, like citrus fruit, melons. If they have an issue with their potassium, okay, it's too low, then you would teach them foods with high potassium like bananas, citrus fruits, raisins. If they had a problem with their salt, too much salt, hypernatremia, you want to teach them how to avoid like processed foods, lunch meats, etc. And eliminate the use of table salt. Also, if they have a problem with their potassium, you want to teach them about fake salt or salt substitutes because they're generally high in potassium. Also, you want to teach the patient about foods that they should avoid. The patient should be able to identify different foods regarding their dietary plan and should be able to describe a plan that they should eat over a 24-hour period. Modifying fluid intake, okay? So depending on what the issue is, the intake may have to be increased, decreased, or modified. So what you have to do is first attempt to identify the appropriate fluid modification. So like if the patient is in kidney failure or heart failure, then you might have to put them on a fluid restriction. Now, remember, fluid restriction is something that we rarely do with our patient, but we will do it if it's going to cause more harm than good. Okay, and then if our patient is a fluid volume deficit, okay, can we give them fluids by mouth? Do we need to start an IV? So how are we going to do it? And then if we do start an IV, we have to be careful that we don't take our patient in the other direction. Okay, so typically we want our patients to encourage fluids. Okay, that's what we are teaching, is to encourage fluids in a 24-hour period. So we want to have a certain amount per shift. All right, so you know, normally, which most patients, are encouragement of fluids in a 24-hour period is going to be somewhere between 2 and 3 liters of fluid is what we're going to want them to have. Also, think about ice. You know, ice is a fluid. Anything at room temperature is a fluid. So if it's Jello, pudding, it's going to be a fluid. Ice is usually half its measurement. Okay, so if you're doing intake and output and you have 4 cups of ice, okay, when it's at room temperature, it's going to equal 2 cups. Okay, once it melts. So it's going to be half of what the original fluids were. You have to consider all fluids, okay? Fluids that are used for medications, fluids that come from IV. So however those fluids go in, you have to make sure that you take accountability in for all those fluids. If you have to restrict, you know, fluids, then you're going to indicate the amount of fluid that the person should have in a 24-hour period, and you want to make sure that you spread that out throughout the day. Okay, you're giving them a few ounces here, a few ounces there, so the person's not constantly feeling thirsty. Okay, because that's going to be an issue. So giving these fluids every 1 to 2 hours and in between meals is the best way to relieve those feelings of thirst. Sometimes you can use ice chips, but you have to remember that you know, you have to count those ice chips in, okay? Because ice chips are still you know, part of water. When patients need to restrict fluids, we report they're going to report probably a thirst or a dry mouth. So offering them dry, salty, or sweet foods is going to make that worse. So you want to try to not really give them those type of foods, okay? And then also doing oral hygiene frequently can help decrease, and lubricating the lips can help decrease that dryness or make the patient a little more comfortable. With fluid and electrolyte and acid-base imbalances, often medications are given. You have to understand what the medications are, what the therapeutic effects are going to be, okay, and any life-threatening adverse effects, okay. You have to also consider any other medications that the patient's on, okay, like steroids, hormone replacements. You want to think about all that. Diuretics. Okay, what else is the patient on? What are they getting? What are we mixing? Mineral electrolyte preparations. These are sometimes prescribed to correct electrolyte imbalances. So you want to make sure that you're giving them correctly, that you're following the directions. Okay. You need to monitor, you know, for certain things when you're giving them. So you want to understand, you know, what am I should be monitoring for, and what are the therapeutic effects? What should I be assessing for? What would I not expect? Okay, and what would be the adverse effects? Diuretics, you have to be careful of, okay? They're for excreting sodium, water, and other electrolytes through the kidneys. Okay, so the kidneys have to be working well, and then you have to be monitoring other things for the patient's safety, like ionos and electrolytes like potassium. All right, because potassium imbalances can lead to cardiac issues, arrhythmias, and you know, for sure. IV therapy. We have to be careful when we're giving IV therapy. We have to be monitoring it closely, and we have to be watching for overload. Okay, so you're responsible for knowing and evaluating all the orders before you administer it, and also for knowing what that patient's baseline status is, so when something changes, you know it changed. Also, you want to be careful, okay, about certain levels, like potassium levels, okay? If it's elevated and they're receiving something with potassium in it, like lactated ringers, you need to notify the physician right away, okay, and get the order revised. So those kind of things you have to also pay attention to. Blood and blood product replacements. What are your guidelines for them? Uh, who is allowed to do it, and what's required before you do it. Also, total parental nutrition. What are going to be some of the side effects of it? Can it lead to a fluid volume deficit? And what other issues can that cause? Okay, like high blood sugars. So those are the kind of things you need to think about with that. All right, and high risk for infection, especially pneumonia. All right, so how else can that affect the body? There's fluid and electrolytes that come in that. So you can end up with your patient with fluid volume overload or some sort of electrolyte issue because it is high in different nutrients. Okay, and then allaying the patient's anxiety, being able to reassure them, teach them, and help them understand what's going on. Okay, and then also appropriate patient and family teaching. All right, we talked already about the electrolyte preparations, diuretics. Most diuretics are going to have some effect. The loop diuretics will have an effect on the patient's hydration status over time. They can become dehydrated, and that'll sometimes show up in their specific gravity. Also, it can affect their potassium levels if it's a loop diuretic or a thiazide diuretic. So you have to be careful with that. And what other things are issues with these patients. So like thiazide diuretics, they're sulfa drugs. So if your patient has a sulfa allergy, you have to be considerate with that. There's different things. So you want to know about what you're giving and why you're giving it. And then IV therapy, are we using hypertonic, isotonic, or hypotonic solutions? Remember the isotonic solutions, we give those usually for states like dehydration. It's normal saline is the only thing that can be given with blood products. Okay. Isotonic solutions, when you give them, they stay where you put them. Okay. Hypertonic, when you give them, they are going to pull from the cells. They're going to pull fluid from the cells into the bloodstream if it's hypertonic, and that can cause the cells to shrink. And if it's hypotonic, it's going to pull from the bloodstream into the cells, and then that can cause the cells to swell. All right, so for IV therapy, we use a number of different venous access devices. Okay, you should be familiar with some of them. PIV, that's a peripheral line, and those are usually used for very short term, usually 72 to 96 hours. Okay, and we're monitoring them for redness and discomfort. You want to use the smallest gauge possible so that you don't induce phlebitis in your patient. That could happen if you hit like the side of the vein. It would cause damage to it and cause it to have some inflammation and some redness and discomfort. All right, so different catheters are used based on the patient's site and sometimes what type of medications that they're giving. Another type of catheter is a midline. This is usually put into the upper arm in the basilic or the cephalic or the brachial. They're longer than 3 inches, and the distal tip is going to go into the basilic, cephalic, or brachial vein. Okay, just distal to the shoulder, and it's not a central line. It's not used to infuse anything that's vesicant or hyperosmolar, okay, or irritating. So they're recommended to be kept in no longer than 4 weeks, but for at least 1 week. And we only replace them if there's a reason, like the patient developed phlebitis or some sort of compromise. Central venous access devices are also components that we use, and these can be done in acute, ambulatory, or a subacute setting, including the home or long-term care facility. They provide access for a number of different IV fluids, medications, blood products, or parental nutrition solutions. They also allow means for us to monitor the patient's blood and sample the blood and culture it, okay? And the devices usually have a tip that terminates in some central venous area, okay, usually in the lower 1/3 of the superior vena cava in the right atrium. So ultrasound is used when it's inserted, to verify placement and to decrease the risk for complications. The CD recommends the ultrasound guidance and specifically train people to place it. And then the confirmation of that positioning is made once it's been inserted through ultrasound or X-ray. Midlines, PICC lines, and other central devices are not routinely changed because it puts the patient at risk for infection. However, they would be changed if there was a greater risk at leaving it in than there was at changing it. But for a central venous device, it would be replaced if there was a suspicion or if thought that a catheter bloodstream infection existed. So types of central venous access devices include PICC lines, non-tunneled percutaneous central venous catheters, tunneled central venous catheters, and implanted ports. PICC lines, they go into a peripheral vein, usually basilic, cubital, medium cubital, or brachial, or cephalic. Some specialty trained nurses or advanced practitioners can put the catheter in. It can be inserted in what we call an interventional radiology unit, and some places even do it at the bedside. We have to verify it before we use it. Okay, so we'll do that with that X-ray. They can have one or multiple lumens, and they're used extensively in the home environment for IV therapy. They become increasingly common access devices for acute care settings, especially for patients that are going to require some type of long-term therapy between 6 weeks and 6 months. They're only placed when needed. That is when the catheter is no longer patent, or they're only replaced, they're only replaced as needed, and that's when it's not patent or if the site looks infected. So these would be indicated if we were giving IV antibiotics for a period of longer than 1 week, parental nutrition, chemo, some sort of continuous narcotic, any kind of vesicant or hyperosmolar solution, some blood components, other specific medications like vasopressors or anticoagulants, and long-term rehydration. The advantages are they're less risky, so not as much chance for complications. They don't cause as much nerve damage, not as much risk of a pneumothorax, okay, because it's inserted peripherally and less chance for stenosis. The non-tunneled lines, these have a shorter dwell time of less than 14 days. They can have double, triple, or quadruple lumens, and they're generally greater than 8 centimeters depending on the patient's size. They're put in through the skin into the internal jugular, subclavian, or femoral vein, and the tip would be in the femoral vein or the thoracic inferior vena cava just above the diaphragm. These are used for short-term critical access for patients that are unstable. And the CDC recommends that we don't use the femoral vein for central venous access in an adult patient. Central venous access is associated with a high risk for complications, and so we want to be careful about that because those complications are going to end up being bloodstream infections and so that could ultimately take our patient out. Pneumothorax is also a potential complication whenever a catheter is placed into the subclavian vein, so we have to be worried about that. With the tunneled catheter, this is for long-term use, and it's going to go into either the internal or external jugular or subclavian vein. The length of the catheter, it will be greater than 8 centimeters. They're approximately 90 centimeters on average, and that depends on the patient's size. It's tunneled through the subacute tissue under the chin around the mid-chest for 3 to 6 inches to its exit site. The device is usually sutured into place in the beginning, but then after about 7 to 14 days, the sutures are taken out. The subacute tissue attaches to a Dacron polyester cuff around the cath, and that helps stabilize the catheter and minimize the patient's risk for infection. Once that site is healed, then a dressing is not required over it. That tunneled catheter is associated with a lower incidence of infection than the non-tunneled catheter. Another type of long-term central vascular device is an implanted port, and this has a subcutaneous injection port that's attached to the catheter. The catheter tip goes into the lower segment of the superior vena cava near the CAJ, or the cavo-atrial junction, and it goes at the point where the superior vena cava meets and meshes into that superior wall of the right atrium. So it's usually going to be like in some pocket of the upper chest wall. The port is placed in an antecubital area of the arm, is referred to as a peripheral access system port. So we confirm the tip location by either an after procedure chest radiography or by placement procedure, or by technology used during the placement procedure, which is generally required before we use the line, and it has to be documented in the patient's chart. When it's not in use, we should not have any external parts visible, and there's a special needle called a non-coring needle that goes through the skin and into the rubber septum and into the port reservoir when we want to access the system. These implanted ports require minimal care, but they can be uncomfortable, okay? And that has to do with accessing the port. All right, so that might be a disadvantage for some people. Implanted ports are associated with the lowest risk of catheter-related bloodstream infections, and they also improve the patient's self-image. But surgery is required to remove the catheter. For peripheral venous catheter, you're going to assess for the safest, most appropriate location, suitability of the particular vein for the PIV is variable depending on the person's circumstances. So you're looking at accessibility of the vein and, you know, all those kind of things. Is the following statement true or false? A central venous access device provides access for a variety of IV fluids, medications, blood products, and TPN solutions, and allows a means for hemodynamic monitoring and blood sampling. So that would be true, right? Those central venous devices allow access, provide a variety of IV fluids, medications, blood products, and TPN. We can use it for hemodynamic blood monitoring and sampling. So when we're doing those vein selections, again, accessibility of the vein. How good is that vein? What condition is it in? All right. What type of fluid are we infusing? Can the vein handle it? What is the anticipated duration of the infusion? Okay, because if we're giving it over a long period of time, then we might not be able to go with something like a PIV. We might have to go with the central line. If we're only giving it for a week, then we might be able to go with something like a midline. So this is for placement of that PICC line. All right, so we're going either in the cephalic, the basilic, okay, one of those areas. Administering blood and blood products. So a blood transfusion is infusing either whole blood or a blood component such as plasma or red blood cells, cryoprecipitate, or platelets into the patient's vein. Red blood cells carry that oxygen from the lungs to all tissues in the body. Oxygen is essential to maintain that cell function and cell integrity. Platelets, coagulation factors that are found in the cryoprecipitate, are essential to help establish homeostasis during an injury or some invasive procedure such as surgery. The blood components help promote normal blood clotting and are important to prevent excessive blood loss. When we give them, though, we have to be careful about risks that can be involved. Life-threatening complications include severe reactions like anaphylaxis, a hemolytic reaction, a transfusion-related acute lung injury, and circulatory overload. Another complication could be transmission of an infectious disease that might be associated with the blood transfusion. So we have to think about the potential benefits versus the risks. Now, the person receiving the blood is the recipient, and the person giving the blood is the donor. Before that blood product can be given, we have to determine if the donor is compatible with the patient that is receiving it. If they're not compatible, clumping and hemolysis of the patient receiving the blood can occur along with death. So we do a process in the lab called blood typing, and then also we do a compatibility test between the specimens called cross-matching. Blood type is something we inherit from our parents, okay? And this talks about the type of blood that we actually have and our antibodies and antigens. So what you really are saying to people when you say that you are blood type A is that the cells in your body make antibodies only to type B antigens. The type A antigen on the cell is not recognized. The surface antigen can be attached to the surface of your blood cells or to proteins anywhere in your body. This means your body makes antibodies against type B antigens. If your blood is positive or negative, refers to the Rh factor. So in essence, you kill off the cells containing B antigens, allowing type A to be dominant. If you're type B, the situation is reversed. If your cells have type B antigens attached, your body makes antibodies against only type A. Once type A antigens are kept at bay, your blood cells show type B as the dominant type. You can receive type B or type O blood, and you can donate to people with type B or type AB. If you're type AB, your cells do not make antibodies against type A or type B surface antigens. So you can receive blood from a donor with any blood type. But you can donate blood only to other people with type A or B. And if your blood type is O, your cells make antibodies against both type A and type B antigens. So this means if you need blood, you can only receive type O blood, but you can donate blood to anybody. So you're a universal donor. Type O is the most common. The Rh factor is also inherited in human blood. There's 5 antigens in the system, but the one designated D is of first concern. A person whose blood contains a D antigen is called Rh positive. A person who lacks the D antigen is called Rh negative. An Rh negative person must receive blood from another Rh negative person. If Rh positive blood is given to an Rh negative person, the recipient will develop an anti-Rh agglutinin. Subsequent transfusion with Rh positive blood may cause a serious reaction with clumping and hemolysis of the red blood cells. So we have to be super careful when we select our blood donor. The donor has to be the blood type, okay? It has to be free from infection, disease, okay? And it has to have the same RH factor. All right, so those kind of things we want to be careful for. Also, we want to watch to make sure we're not transferring bacteria, viruses, parasites, those kind of things. We're using screening questions when we get blood from the donor, and we can do specific lab tests on the blood work to ensure that there's no infectious organisms present or transmitted. All right, so the blood that's donated will be tested for things like Chagas disease, HIV, Hep C, syphilis, West Nile virus, and some other things. Okay, so that'll be carefully done, and the donor will be carefully also checked at the time of the donation. If someone knows in advance that they're giving blood or that they're going to need blood, they can do an autologous transfusion where they put their own blood up, okay, and they can donate blood every 4 to 7 days before the surgery is planned, as long as they meet the donation guidelines. For initiation of transfusions, we want to monitor the patient. We're watching for transfusion reactions. You would want to get baseline vital signs before you start. You would want to stay with the patient for at least the first 15 minutes. A lot of patients have had transfusion reactions or even resulted in death. You have to confirm the patient's identity with at least 2 independent recipient identifiers. So you need the patient's full name and date of birth. If you're in the long-term setting, you're going to confirm this information on the patient's ID band. You also have to confirm the patient's blood type and RH factor prior to the infusion. And you should have 2 nurses check the bag. You also want to check the expiration date on the blood itself, the time it was issued, along with looking at the blood product itself to make sure that there's nothing in it that looks abnormal. You're going to use a 20 to 24 gauge IV access. If rapid infusion is required, you would take it up to a 14 or an 8, between a 14 and an 18. And then you're going to give that blood with an inline filter that's appropriate for what kind of blood that you're giving. You want to make sure that you don't leave the blood out for longer than 4 hours. You want to start infusing as soon as you get it, so within 15 to 20 minutes. You're checking again those vital signs before you start the infusion within 5 to 15 minutes after you start the infusion, and then again after the infusion is completed, as well as any time that the patient's condition looks like they need it. If the patient's temperature is 100 or higher, you would notify the physician. Return any blood back to the bank that's not used within 30 minutes after its arrival. You're going to administer and complete those blood units within 4 hours, and that's going to help reduce the risk of bacterial contamination. Anything that has been infusing for more than 4 hours, you need to discontinue. Transfusion reactions can occur within the 24 hours after admission, or 1 day to several days after the transfusion, and those are considered a delayed reaction. Table 4010 in your book describes some of the transfusion reactions that can occur, especially those serious and life-threatening ones, and also details steps of the transfusion process.